Thank you.
Good morning. Thank you again for the invitation, a privilege of the podium. Yes, lots of changes in rectal cancer, and I decided to highlight 5 points. I'm going to try to squeeze them in 12 minutes. So the first is a message to your gastroenterologist. Do not snare rectal polyps before staging. We'll go and see why. EMVI, it's extramural venous invasion, is something that basically shows that on the MRI a tumor thrombus in the veins that are outside the rectum. Watch and wait, I'm sure you've heard of it, and we're about to see the end of laparoscopic surgery for rectal cancer. I'll tell you why. And is there any role for transanal minimally surgery, basically endoscopic treatment of some rectal condition? So the do not snare rectal polyps comes from the fact that if you do snare rectal polyps, you know what a snare is. With a hot snare will create a reaction in lymph nodes that might be very difficult to distinguish. Let me show you a case. This is a 50-year-old male with a 2 centimeter sessile polyp. Of course, we're talking only on sessile polyps. It is snared, and the pathology report says an adenocarcinoma in a tubulovilous adenoma. The margins are, of course, cauterized, means burned. And so you end up doing a rectal ultrasound that is telling you it's a T2N1. Then you end up doing a low anterior resection of the rectum on this basis, and you end up finding 10 normal lymph nodes. Another case. You have a 46-year-old woman that has a 1.5 centimeter sessile polyp, but it's at 3 centimeters from the anal verge. So this is going to be a risk for an APR. And at the pathology report, it's an adenocarcinoma in a tubulovilous adenoma. So you see on the image the lymph node pointed by the green arrow. What do you do now? Are you going to do an APR? I didn't. I did a PET scan. And the PET scan shows me that lymph node is non-metastatic. Again, a lot of anxiety for the family, a lot of confusion, so big issue in the United States with gastroenterologists, snaring polyps. The next thing is the extramural venous invasion. This is something that we observe in MRI, and it's the presence of malignant cells in blood vessels that are outside the muscularis mucosa. So just to give you images, can you see the white arrow is pointing at something that looks like a snake. Here you see other images. They are divided in different scores. This is a score severity 4, which is one of the most severe. You can distinguish sometimes the tumor edge from a EMVI. Bottom line is that EMVI needs to go to preoperative chemotherapy. That's the message. And that is not the same to say neoadjuvant chemoradiation. I'm just saying chemotherapy only before going to further treatment. Watch and wait, as you know, came from some data in Brazil. Basically, give you an example. This is a tumor before neoadjuvant, and then it used to be 8 weeks, and now we're going up to 12 weeks. But in any case, this is an image of what is called a complete clinical response. The problem with this approach is that if you look at these data from the Journal of the American College of Surgeons on a retrospective review, only 25% of the patients actually had a pathologic complete response. I mean, clinical is something, pathological is something else. Of course, how do you get the pathologic response? By excising the scar. And 75% of those that had a so-called clinical response had actually residual cancer cells. This is Jose Guilhem from Sloan Kettering Memorial Cancer Center in New York City. And he found 15% only of the so-called clinical response having pathologic response. So basically, the bottom line is that clinical response does not predict pathologic response. This is a nice overview with 4 papers. MNSK, CC, it's Sloan Kettering, Haber-Gamma, it's in Brazil, and another study down the line. Basically, you see the column called the local regrowth, basically recurrence. It's ranging from 18% to 38% local recurrence. So this is the true view of complete clinical response. Probably the most important change is now the role of laparoscopic surgery in rectal cancer. We all know that the rectal cancer is in the pelvis. We all know that the pelvis can be android, very narrow, or can be gynecoid. So this is a very nice study from the Netherlands that showed that you have to go through the bone in order to staple it. But my point is more about dissection. If you use the laparoscopic surgery, you risk to be operating like Pinocchio would operate, right? With straight arms. So the echoes, if you think of the human hand, we have 2 more movements, so 6 degrees of freedom as opposed to 4. I'm sure you just let me use a few seconds on this. The EchoSOG trial, the first one on the top, published in JAMA, it's an American study done by colorectal surgeons. The conclusion of this study, comparing open to laparoscopic, was that open is better, to put it in simple English, or that laparoscopic is inferior. The most important point to understand, I heard talks about esophageal cancer earlier and talks about gastric cancer. So let me have a parenthesis on this. We often use survival at 3 years and 5 years. And I have a problem with that. And the problem is that there is a lot of confounding factors if you use survival. If you use survival to judge the quality of surgery, you're forgetting there's a lot of patients that are having neutropenia and maybe they're going to skip chemotherapy. They're not going to be able to have chemotherapy. So there are many other confounding factors if you use survival, particularly if you don't use cancer-specific survival, of course. So for that reason, I was part of the EchoSOG. We decided to use pathology, basically the pathology report of what the surgeon does, which is, as you stated there, circumferential resection margin and the quality of the TME, no survival. And the a la carte, which is another study from Australia, they did the same. And if you judge just the margin and the quality of the TME, open surgery was far much better than laparoscopic surgery. Now, the Europeans did their own study, the COLO2 trial, which, however, used survival, and their conclusion was different. So it is obvious that it's very unlikely that we're going to go back to open surgery. Very unlikely. So the reality is what is going to happen with laparoscopic surgery. I think that probably what's going to happen is that robotic surgery is going to take over completely low rectal cancer. And this is a study that I want to show you. I did several years ago when I started doing robotic surgery. I compared myself to myself to myself. Basically, I did my first 20 cases of robotic surgery. Well, in America, you have to do proctoring. You have to go to a cadaver course. You have to have a proctor. A proctor is somebody that you have to pay $5,000 every time he comes. And he has to stand in the room and watch you operating and then sign off that you are able to operate. So it's a long process. But basically, these are my first 20 cases in robotic surgery in rectal cancer. And then I matched the patient with my previous patients, gender, age, level of tumor, staging, and so like that. And I found out that despite I was learning, the learning curve, robotic surgery, I was already much better than I was in laparoscopy. And it wasn't my being good, it was the robot. It was the machine that was articulating the Pinocchio arms. And finally, I could go far away from the tumor. I could go anywhere I wanted to go because of the articulation of the... So you can see that the margins were much better in robotic surgery. One point in criticism of the robot, you can't feel anything. So it's all visual. So you better be careful that you're not tearing the fascia of the mesorectum, because if you tear, then you're going to have a very poor quality of TME. So it's not all roses. Finally, this is my last point, transannal minimally invasive surgery. We know the history, I'm not going to go through that. My point is this: in my practice, if I have a tumor that is benign, I will definitely use transannal surgery. If I have a very frail, I'm not saying old, I'm saying frail, very big difference. If I have a very frail patient, I would consider doing palliative surgery, transannal. So this is a case of a 7 to 8 centimeter from the anal verge. It's a posterior rectal mass. You can see it on the slide very clearly. It's posterior, and it's a carcinoid in a woman, in a young African-American woman. The way I do it, I used to use the SI, now I have the XI. I have these reduced size trocars. Most important, notice, I don't have a pointer, or I do actually. Let me see, yeah. Notice this trocar, that's the end seal. This is very important to maintain the pneumorectum. You know the pneumorectum, basically, if you don't have that, the rectum is going to collapse and open, collapse and open. It's very important to maintain the pneumorectum steady. So I use this device. It's 10 millimeters. It's a little big, but still. So this is the approach. You can see the light. This is like a single port, basically, adaptation to the anus. And this is the carcinoid tumor that I removed. Now, if it's posterior wall, you can get away with anything. You see, I don't even close the posterior wall. It's all left open. But it closes nicely, and the patient can eat. This is a rectal contrast. You can see the Foley balloon for rectal contrast CT scan before getting to eat. So in conclusion, I think it's very important to avoid hot snare of a sessile rectal polyp. It's going to confuse and create a lot of anxiety. They need to be staged first, and then you can decide the therapy. The presence of cancer cells in veins outside the rectum should be treated with preoperative chemotherapy. Be careful with watching weight, because if you look at the endoscopically, it doesn't mean that it is gone. I don't think that EchoSOG will bring us back to open surgery. I think robotic surgery will take over low rectal cancer, and I think robotic transannal minimally invasive surgery is good for benign tumors and frail older rectal cancer patients. Thank you.